that I didn't feel confident are going to heal. And I followed them meticulously since January of 2013. We're going to go over a case like that later.
The first step, bacteria have to come in contact with the surface. The bacteria that stay turn off the flagella-making genes and turn on the genes that produce the pili. The pili's twitching motility allows the bacteria to sniff out chemicals and aggregate on the surface.
They also start to produce the extracellular polymeric substances that act as that glue to stick them to the surface at that point.
Okay, 4 hours into it, and it's pretty benign. Disgusting, isn't it? Who wants to go brush your teeth?
As the biofilm thickens, the bacteria make small signal molecules and wash over the other bacteria in the polymeric matrix. When the chemical messages reach a critical concentration, the bacteria start piling onto one another in diverse and dynamic structures. The ability to recognize and react to a crowd is called quorum sensing.
Quorum sensing, something that was developed in the mid-90s as I was going through school. And this is how we found out that bacteria actually does communicate with chemicals.
But like anthills, biofilms are dynamic. If they get too large or parts of the biofilm don't get enough nutrients, some bacteria break away to form new biofilms.
Who wants to brush their teeth?
The flagellum again and downregulate the pili and will actually evacuate certain portions of the biofilm and swim back off into the nutrient.
What that says is that the biofilm, the planktonic bacteria, breaks off and it becomes planktonic entities again. And that's what happens with Pseudomonas aeruginosa, which in cystic fibrosis. It's a really, really bad planktonic disease, but when it's in biofilm form, it's not as bad. So people with cystic fibrosis, they go 5 months at a time, then some of the biofilm will break off, it becomes planktonic, then they go to get an acute exacerbation, and that's usually what ends up to the demise of the patient. Again, bacteria, my favorite study. Now, I got to tell you something. They use 21 notobiotics rat and 15 conventional. How hard is it to get a conventional rat? Why didn't they do 21 and 21? It's just OCD, I'm sorry. But anyway, it was up until 1999, we did not understand how biofilm and chronic diseases affect us, basically, until Costerton came about and he wrote his very, very famous paper in Science Journal 1999. And we learned a lot since.
I think there's an increasing recognition that biofilms play a role in chronic diseases. And the reason for that is that biofilms are very difficult to eradicate. They live on surfaces, they produce extracellular material that can defend themselves against human immune cells or antibiotics, and therefore they're very difficult to remove. And once they form on the surface, they're very difficult for your body or for drugs to kill.
Stop thinking unicellular organisms.
Bacteria come together when they're threatened. When you have a situation where bacteria are treated with antibiotics that can kill them, or when a strong immune system responds to bacteria by producing cytokines or chemokines or other agents that are able to destroy the bacteria and to eliminate them from the body, these bacteria have a choice. They can either stay as an individual bacteria and die, or they can change their form and instead of being a planktonic bacteria, form biofilms.
This is how autoinducers work. You have the signaling producing protein in a bacteria which produces autoinducers, and it has to come to a critical concentration, and at that point a gene expression is achieved. They all the bacteria of all the species, they listen and they all in unison do whatever they're programmed to do. It's fascinating. It's just like how we are communicating with ourselves. It's just fascinating. Once you get into deep with the biofilm, it's amazing. So the microbial communities, they talk to each other and they agree to what they want to do. They want to do symbiosis, virulence, competence, which is the acquiring of DNA of different species, and to strengthen their own DNA. Antibiotic production. Did you ever think where antibiotics came from? They came from bacteria. Antibiotics are produced by bacteria to defend themselves against other bacteria. So it's fascinating. And different species, they talk to different species. This is, for example, the gram-negative bacteria autoinducer, acyl homoserine lactone, which is the predominant one that's produced by Pseudomonas aeruginosa. And Pseudomonas aeruginosa, if you want to study biofilm, this is what you're going to be studying. Okay, so Costerton and Donlan, they wrote another paper, and that paper is the survival mechanisms of clinically relevant microorganisms. Did you guys read this? Did you read it in school? You know about it. I mean, that's what I mean. You were exposed to it. Okay. So the take-home message is that it creates the bacterial biofilm creates physical barrier. It's called the extracellular polymeric substance. It builds its own house and its own defenses, physical defenses. It reduces the growth and the metabolic rate. So the metabolic rate of the biofilm decreases, so they don't want that much food. They don't need to be on hyper mode all the time. It alters the pH concentration gradient, so antibiotics and other microbicidal agents are not effective. It increases the expression of efflux pump, which is, the efflux pump is the bacterial's ability. Have you ever seen a movie where somebody throws a grenade at Dr. Friedman and he takes that grenade and throws it back at me? That's what the efflux pump does. The grenade being antibiotics or whatever, it gets into the bacterial cell and the efflux pump just ejects it back. Fascinating, isn't it? And the detachment and the seeding of chronic state into acute state. This is impressive. Okay, look at this. This shows what it takes to eradicate planktonic bacteria versus the biofilm of the same species. For example, Strep aureus with vancomycin, it takes 2 micrograms per milliliter to eradicate the bacteria and 20 micrograms per milliliter. So it's 10 times the same bacteria. It's just different forms, free swimming or biofilm. Pseudomonas aeruginosa, 1 microgram versus 1,024. 1,024 times it takes the amount of efforts on antibiotics to kill Pseudomonas aeruginosa. That's why it's virulent and it's studied, and that's why people study it when they're studying biofilms. E. coli, 2 to 512. That's 256 times. And another Pseudomonas species, 8 to 800, 100 times. And Strep sanguis is 0.063 to 3.15, which is 50 times. So that demonstrates that planktonic bacteria and the chronic biofilm countertype is.
Now, what we know about these communities is that it takes such a greater concentration of antibiotic to get rid of them that it is not indicated. You're talking about anywhere from 500 to 5,000 times the concentration that normally is the minimum inhibitory concentration of antibiotic that it takes to kill bacteria in a biofilm.
Look at this. This is the glutaraldehyde penetration and eradication of Pseudomonas aeruginosa. The blue is a planktonic phase. It takes a few minutes, and you get to -3 log, which is 99.9% bacterial reduction. It takes 13 hours to get to that level with a biofilm. The same bacteria, monospecies. Okay? But this is the bad news to the endodontists in the audience. Look at an hour and a half. Look at this. An hour and a half of antibacterial medication, which is hypochlorite or whatever. This is how much we reduce. Nothing. Okay? That is not to say that we don't remove the bacteria. We don't just let that solution sit there and by itself and let it do its thing. We have something to do with it, of course. And that's why we implement different things. Sorry about that. Okay, we have to energize our solution. Some people use gentle wave, which is acoustic streaming, and other people use lasers, which is kinetic energy in the solution. And ultrasonic is the standard, which we use at UOP, as I use that too. And as we see, it penetrates because it works as passive and active. That's my way of thinking at it. The weakest one, in my opinion, would be the endovac, because all it does is brings the solution down into the canal passively. In my opinion, it doesn't work as well. So, like I said, I use the ultrasonic energy because I have more control over it. I can use it for as much as I want or as little as I want. I can use it in different deliveries and all of that. And as we see, we can get into lateral canals. And remember back from histology, this is what teeth look like. This is what dentin looks like. It has dentinal tubules. And dentinal tubules is certainly, it gets infected. The green over here is nothing, it's not good, it's bad. This is bacteria in the dentinal tubules. Okay, so this is the reality of what we're dealing with. Okay, let's go over teeth now. Okay, this patient was referred as an emergency, and I have an appointment with him at 6:30 p.m., right? The patient was in so much pain. 2 Septicane injections were given, did absolutely nothing. And his pain is coming from tooth number 12, exquisitely tender to touch. But then again, 13 was not happy, 14 was not happy, but 12 is the worst. Okay, there is a lot of diagnosis that went through this, right? But we don't have time for all of this. So this is another view, because this is a view of 12. This is another view because I wanted to see if there's 3 roots, and of course there was. But that's not what the problem is. The problem was this tooth number 10. It blew an acute infection, not a chronic infection. So tooth number, do you see that? Did you notice the lesion? Yeah. So there was a lesion up above the tooth, and as soon as I opened it, this is what happened. And I expected that, because this is endo disease is not endo disease. You have to separate in your mind. Is it chronic or acute? Because acute is handled one way, chronic is handled another. There is something that we learned somewhere in school, that if you can dry the canal, you can fill it. That only applies to acute cases, not to chronic cases. Because chronic cases are not going to weep. They could be infected, but they're not going to weep. So to me, that's not a deciding factor. This case, you do not obturate unless you can dry the canal. But this is easily recoverable. This is not that hard. So this is the tooth, this is the final, and 8 weeks later, this is how it heals. And I brought the patient back and I told him, I want to take a scan in 2 months. Do you mind? He's an older man, but very strong. And he goes, what, do you have doubts that it's going to? I said, no, but I want to demonstrate it. Do you mind? He goes, sure, no problem. So this is the before, and this is the after. He came in knowing that he's doing this for science, or for this. And I showed you this in part 1, right? Do you remember? Yeah. So this is another case. This is the craziest thing ever. This patient was mugged in a foreign country, lost all his anterior teeth. He's now 62, I believe, and the bridge is loose at the distal abutments at 11. So the dentist sends it to me the end of the year. Samer, do you think we need to do any endos or retreats or whatever? So I take a scan, and we all see that there is a tiny lesion over here on tooth number 10. So I called the dentist. I said, yes, we need to treat number 10. He goes, number 10? I thought you were going to tell me tooth number 11 has it. I said, no, 11 is fine. Okay, so the patient goes back, and we close up for the end of the year. And I had an appointment with him, I think, January 4th, the next year. And so this is how it was. And he comes back January 4th looking like this. Look at this. The patient ended up in the hospital because antibiotics could not control it. I didn't know anything about it because the patient knew that I wasn't going to be in town, and I said, what is he going to do? So we started with the amoxicillins and the azithromycin, then the cephalosporins, then he ended up. But the problem is that they started for 2 days and they changed. 2 days and they changed. Don't do that. Don't do that. So so this is what it looked like when I saw him. I mean, he came to the office for the treatment of number 10, and he goes, "You're not going to believe what I went through." So I said, "I want to take another scan." So 4 weeks later, this is what happens. This much bone destruction happened in 4 weeks. So if we extract the tooth at this point, what do you think is going to happen? That area will never heal. Is that right, Mike?
Never say never.
I mean, it's just, it's hard for it to, it's a through and through lesion and things like that. So this is December, this is January, and what happened was that the patient went back to the dentist saying he removed the bridge and temporized it. Okay? Then I treated it with intracanal medication. This is a month later, 4 weeks later. Notice the lateral canal. So this is in January, this is the final in February, and this is 6 months later. Okay? So he's actually healed in 6 months. Do you see that? This is the most bizarre thing ever. Look at that. It's healed from that big hole. So we go from good bone, no bone, to good bone again in 6 months. Well, technically 7 months. And it's all about bacteria. But this is a planktonic infection, this is not a biofilm infection. This is bacteria that went into bone and they're trying to kill the patient. They're easy to eradicate because they're not sophisticated. This is working in dentistry, you guys. I got this from, this is a hygienist, an Instagram of hygienist. Do you know who that is? Yeah, but some young people don't know who that is, believe it or not. I gave a talk one time and they go, "No." I'm going, "Really?" Anyway, this is one of my favorite people, Kim Lewis at Northeastern University. I just want you to hear him talk, that's all.
The paradox of chronic infections goes like this. You can take an antibiotic that kills a pathogen, let us say E. coli, causes an infection, urinary tract infection. And the patient that was treated with this antibiotic did not get better. It's a chronic relapsing infection. The pathogen is isolated, is tested on a petri dish, and this antibiotic prevents the growth of this pathogen into a colony on the petri dish. So here's the paradox. The antibiotic is perfectly effective on a petri dish and completely ineffective in the human infected with this pathogen. This happens with each and every chronic disease. Some chronic diseases are completely untreatable in the West, in the developed country.
Okay, enough microbiology. Let's go back to endo and implant. Okay? So is it endo or implant? I wish I knew how to do implants. I'd be giving you implants right now, but I really don't. Okay, this case, interesting case. Significant pain upon chewing. Tooth number 30 started yesterday. This endo was done a very long time ago. And it so happened to be done by a very good endodontist. I mean, a really top-notch endodontist. Very handsome, too. Very handsome guy. So what would you do here? Percussion sensitivity. What do you think is the problem? Yeah. Lateral canal. Yes, that's right. Well, it's got to be something, right? So digging the history with that, because I'm interested, which was not hard. You know, I went into my computer, I found my x-rays, you know, because I did this in 2002. I was a single man at that point. I didn't even meet my wife. It was a long time ago. So I dug it up and I looked at it and I studied it. I said, okay, the endo went fine. And I'm sure you guys are curious about this. This was my own interpretation on how to do the coronal seal. And I did that when I was suspicious or saw mesial or distal marginal ridge cracks. So by seeing this, knowing how I used to practice, knowing that there is a crack up here, now what? Endo or implant? Okay, starting with the fun stuff. What would you do? Being Dr. Azim trained, what would you do? Okay, so what are the options, really? Treatment options are retreat, surgery, or implant. Who goes for a retreat? Retreat. Who goes for surgery? Oh, you get all of them. They can do the surgery in their sleep, by the way. They are very well trained. Very well trained. They can do the surgery in their sleep. Well, I agree with you guys. Surgery. Okay? And I'm going to tell you why. Because up here, by the time you get in there, you're going to hollow out the inside of the tooth. Number one. Number two, I know what the problem here is, or at least I was very suspicious of a mid-mesial canal, not a lateral canal, because of the way the lesion is. If the lesion was here, for example, or here, it will be a lateral canal. And the lateral canal by itself, in that, it's not going to cause it. Okay? That's from my quantification and my experience. So I'm thinking a mid-mesial, so I decided to do surgery. Right? This is not my surgery, by the way. You know that, right? Okay. No, this is just a surgical guide to where to start the osteotomy. You know, okay, good. So this is the surgery. Okay, so I did the surgery, and we all know how difficult this is. This is not easy. So they made mesial, of course. And here, this is my post-surgery scan. I do it just like you guys do. Okay? And this is the mid-mesial right here, and it's right in the center of the canal. Again, it's not easy to do. You guys appreciate what I'm saying. So, sorry, up here, we see the mid-mesial and the two canals, and this is another rendition of a similar case where they have a mid-mesial canal with a lot of apical ramifications. And this is a surgical video showing the mesial buccal canal and the isthmus and the mid-mesial. This is under magnification. They're tiny and they can cause trouble. It takes 20-something years, but anyway. So this is the pre-op, this is the post-surgery, and this is 9 months later. I think it's good healing. No bone graft, no membrane. In this case, okay? Because I don't like to, membranes I can make that argument. And I don't like to use bone grafts because let the bone heal itself. My philosophy. This is not, I'm not telling you this is how you should practice, but this is how I practice. This is the mid-mesial. And it's connected to the mesial buccal, and we trough with the isthmus. And if this is done correctly, you have a 94% chance of it healing. And we've demonstrated that. So this is one of my failures, but I think after, when was it? 2022. After 20 years, I think I'm forgiven. Maybe, I don't know. Okay, any questions or concerns or comments? No? Okay, let's push the envelope a little more. Okay? This patient we have met in 2014, and she had endo done abroad with big lesions. Now she comes to me with tooth number 8, and this was 2014, and we finished the endo in 2016. She was not in pain. She was happy. She was okay. So she comes, and in 2016, we finished the endo, and in 2017, she comes because we're talking about retreatment of these cases, of these teeth, 6 and 7. So we finish it. Okay, so this is January of 2017. This is February of 2017. The intracanal medication, 4 weeks that I place. Okay? And 2019, I bring her in for a post-op because she moved. She went to get her MBA, and she moved, and this is what I see. Retreat, surgery, or implant. Okay, well, before you say surgery, look at this. This is the buccal view. This is the palatal view. Okay? So it's a through and through lesion. I know what you're taught. Okay? You surgerize it with membranes on both sides. Right? Certainly you can do that. Absolutely. So this is 2019 when we did something, and this is 2021. She moved away. She went live with her parents because this was during COVID and the world was crazy. She did not follow up with me a year. I wanted to see it in a year because I wanted quantification. I wanted to see the healing. But it healed. It looks good. And notice, I did fantastic surgery because the root is still there and you can't even tell. You can't even tell. Is that impressive? Yeah? That's crazy. You know what I did, Gabriel? I showed you this case. This is the lesion. This is not a small lesion. Okay? And it's through and through. So I did lesion decompression. Okay? I did 3 weeks lesion decompression. And she put up with me. And she had faith. I mean, it was not easy. And this is black suture, this is silk suture, because it's the kindness the patient can tolerate. So, and after 3, it heals on its own. And this is what we started out with, and this is what we end up with. I know what's on your mind. If bacteria is involved, why did it heal? You asked me that question earlier. I'll answer it later. Okay? So I'll answer it later between us, because so this is what we started with, and this is how it healed. Now, why did I do it crazy like that? Could I have done the surgery? Yes, I could have done the surgery. It could have been done in one visit and everything. But this is what we started out with, through and through lesions. How do they heal? Fibrous union, scars, and that was not acceptable for me or for her. It heals like that with bone, with the decompression, at least that's what I was hoping for, because this is what she was going for. She was going for orthognathic surgery. And we did not want osteotomies in fibrous unions. So that was not acceptable. That was not an option for her. And this is how she is. I took the Spano a year later because I want to monitor things. And if we see the mandible is healing and she's doing great. So this is the osteotomy. This is the titanium bracket. Look where the osteotomies are. Here. Look where the lesion is. And this is how it healed. Superimposed, it would have been right in the osteotomy. So I did not want to challenge the surgery and have things fail. Or have you ever seen a surgery where the maxilla is actually moving? It's a fibrous union healing. That I've seen it once. I was a resident, not endo before, and patient is unaware. It moves like a denture, and that came to mind. That case came to mind. So this is why I wanted it to be that way. And she's happy. She lives in South San Jose, and she still comes and sees me for consults. And I mean, we've known each other for 10 years, 11 years now. So this is how it is, and this is why stepping out of the box. Any questions or concerns? Push the envelope a little more. This is tooth number 15, not tooth number 2. It looks like tooth number 2, but this picture was taken in a mirror. That is hard to do. But Dr. Daria Gafapur, thank you for presenting me with this picture. This case, unique. And the patient, buccal gingival swelling, facial probing to apex. You saw the acute infection. The tooth symptoms started 5 days ago, and the tooth is depressible. The tooth is not doing very well. So let's look at it as a whole. Look at this. Endo. Endo, okay. I love it. That's great. Okay, so this is what we have. This is the reality of what this tooth looks like. Look at this. It's being held by this much bone. Or you can take it out and do nothing, right? Taking it out and doing nothing is not a bad option. It is really not a bad option. it's fine. So we treated the tooth, and it healed. Beautiful. Any questions or concerns?
Summer, how do you rule out fractures on teeth like that?
First of all, if it's an endo tooth, it's a fracture. If it's not an endo tooth, then you look at it. You look at the marginal ridges, and you look at the occlusion, and there is a lot of gut feeling associated with it. But a virgin tooth fracturing, you have to prove it to me. Like that case that I took the second scan on, because I was suspicious. I looked at that first scan, I said, I think this is a fracture, but I cannot be sure. We're going to take another scan. The patient said, absolutely no way. I said, you know what? I'm not proceeding. I have to. This is how it is. Then I took the scan and I showed her. Then why did we not see it the first time? It's like, you moved, but we have to do it right. A lot of it is gut feeling, Mike. It really is. So, you're not going to believe me, and I don't think you're going to fall for this again. So I'm going to demonstrate to you that this thing heals by going tomography time travel. This is a superimposition of two scans. This is nothing fancy. So this is 6 months, and this is 12 months. And if we notice, not much bone has grown from 6 months to 12 months. It's maturing. Most of the bone grows at 6 months. And do you see this bone? This is how this bone was at that level before the infection. Why? How do I say that? With confidence, at least. Is because of quantification. I've looked at a lot of my cases, and I've had a few cases where I had no infection before, infection afterwards, and as it heals the exact same way as before. So this is how it was. Remember I told you, this is the pre-op. Remember what I told you, we're going to go back to this x-ray, Dr. Rink's case? So this is the case that we saw with the 3-rooted bicuspid, right? And this is how it was before. This is the healing. This is the infection. So before the healing, remember we had an pulpitis scan that looks very similar. The reason it doesn't look exactly similar because they're two different machines. So the contrast is not the same. But it is very similar. So this is the pre-infection, infection, healing. And do you see how the bone heals? Exactly the same way. And this is the infection to remind yourselves. Now let's go back to that case again. This is the axial view, infection, healing. Look at this coronal view, infection, healing. Appreciate the buccal plate. You see how that heals? And the cortical plate grows as cortical plate, the cancellous bone grows as cancellous bone. The bone knows exactly what to do. Remove the bad stuff. And this is the sagittal view. So this is to prove to you that this is 6 months. This is the scan pre-op. This is a scan at 6 months. And they have, all these things are date stamped, right? They're date stamped. And this is when the case was finished. October 24th, 23, and this is what the 6 months scan was taken. This is to prove that this is 6 months. Any questions or comments? Yes, sir.
So these like long-standing lesions, there could be associated like a deep probing as you demonstrated. Have you had to refer to a periodontist?
Yes, of course. Yes, of course. But before, because I'm interested in this stuff, before I make a diagnosis, I tried to probe. How was the tooth when you did the crown 6 months ago? Tooth was perfectly fine. Now there's no bone. What's happened? A fracture or an endoperio lesion? Really, because a perio lesion is not going to happen in 6 months or even a year. And a perio lesion is not racist. It's not going to discriminate to one particular part of one particular tooth of the whole mouth in general. Okay, so you get a feeling in how things are. All right, and that is the tooth that had the lateral canals. She had perfectly clear mouth, one crown. I saw the PA before the crown was done, And all the bone was there. So I knew it was a lateral canal. So you have to do the investigation.
I mean, I've seen like cases where the periapical area heals, but if there's like some calculus attached to the root.
Oh, that's different. That's true perio. That's true perio and cemental tears and things like that. Yeah, oh, that's true perio. That's not what I'm interested in showing today. But you recognized that before. You recognized that before. Any other questions or comments? Look at this guy. Remember this guy? Come on, let's push the envelope a little more. Okay? This tooth, pulp necrosis, severe percussion sensitivity. Endo or implant? It's an endo lecture. Who said that? Who said that? He figured me out. I'm not gonna. Yeah, and this is how I did the implant, and it looks beautiful. No, you're not gonna get that from me. I've retired. Remember? So 9 implants. That's a lot. Okay, so what is it? I'm gonna make it easy on you. It's an endo and a separate cyst. They are not together, and that can happen. You know. That can happen. So this is, look at that. And by the scan, I can tell it's a cyst. Could it be a lateral canal causing the cyst? Yes, but not today. Lateral canal is going to cause that big of a cyst? Really? So that's what it is. What about this case? Big lesion. And this is a similar case. This is what it looks like. Now, let's look at that. This is what the lesion looks like. And the lesion here, which is extending the roots. And this is what it looks like on the skin. Endo or perio. I mean, endo or implant, that's what I meant. This one was not probing, so it cannot be perio, right? Endo or implant? Endo? Endo? Okay. Now, which tooth?
The one you treat.
The one I treated. I didn't treat any teeth. Okay, look at this. This is what I want you to do. This is the canine. This is tooth number 22. This is tooth number 21. Number 21 is completely buried in bone. Tooth number 22 is in the lesion. However, tooth number 22 is vital. I don't know. I mean, what would you do? Now we're going through it. This is what it looks like in just a snapshot. It's expensile of the buccal plate. Oh, by the way, this is another case from Dr. Ring's office. Remember, do you know what that is? You know what that is? No, I'll tell you later. So, he's a veterinarian. Mm-hmm. No, not that he's a veterinarian. She knew who he was. So anyway, but I have a theory. I have a theory of veterinarians. They blow big infections like that, and I have a theory about that, but not today. So this is what it looks like.
Dr. Biggs?
Yes, sir.
I mentioned, dog owners have different gut biomes than those who don't own
That's
dogs.
what it is. That's my theory. And I'm drawing that conclusion from that veterinarian that work in the field, big animals, work with cows. So that's my theory, because I've seen huge. So yes, the biomes are different. So this is what it is, okay? Let's look at this. Look at the axial view and tell me what you want to do. Endo, look where the lesion ends. Look at number 22, which is this guy. 21 is not in the lesion. By the way, I tested 21, 19, and 18. They all were negative to the response to cold. Now what? This is tori. This is nothing weird. So I did an endo. on the premolar because it's coming from a lateral canal. Now, can a lateral canal not cause apical breakdown and a huge lateral lesion like that? Can it? Have you ever seen it? Darren has many times, but here, to prove to you it's a lateral canal. And I showed this to a dentist one time, and they're laughing with me, of course. Oh, you perfed. You cannot perf the side of the root like this. Impossible. Cannot. So anyway, lateral canal, and there is a lot of sealer, which is not a big deal. Another thing you can learn today, that sealer in the bone is not going to matter. Not in the sinus, in the bone. Look at this again. Look at this again. Pay attention to the tooth itself, not the lesion. Do you see where the lateral canal is? Do you see how it joins? Do you see that? And I saw that from the pre-op, obviously. Do you see this? So I knew there's a lateral canal, and can a lateral canal cause a lesion like that? Yeah, it's a part of the root canal system. Why not? Why isn't it causing breakdown at the apex? And I got the answer to that, which is significant collagen plug at the end. So bacteria was not able to communicate with the periapical tissue. That's why. So 6 months, and yes, something like that can heal in 6 months. The lesions will heal from the periphery to the apex. So the buccal plate is restored, and this is 6 months. This is the pre-op, and we see here the bone is restored in 6 months. What is this? This is sealer, and the bone is healing right around the sealer. Doesn't care. The alveolar process is very, very resilient. Very resilient. So this is the before, this is the after 6 months. Okay? So this is 6 months post-op, and this is 6 months post-op and 12 months post-op. And the reason I'm including this is because I want you to see what bone does in 6 months and the difference between 6 months and a year. Most of it grows in 6 months, and it matures from 6 months to a year. And I've seen many, many cases like that. Many cases, because I look into, and I'm interested in learning how these things heal. So I'm going slowly. What you're seeing is beam hardening around the sealer. That's why it looks black here. But it's not an infection. And if there is infection, if there is activity, biofilm activity, it will never heal. The buccal plate will never heal. And this is 12 months. Look at it. Just compare the two, and it's going to look exactly the same, except the bone here is going to be more mature, more dense. That black, do you see this? How dense that is? And I followed him for, this is a year. I did 2 and 3 years. I think you restored it last. Right, Dr. Chow? Yeah, you did. Okay, good. All right, very good. So this is a year. So we go from infection immediate after the day of treatment, 6 months later, a year later. And to prove to you that this is 6 months, this is the day of the treatment, the final, and this is the first 6 months post-op. They're time-stamped. I cannot fake this. Have I seen this before? I've seen this before, so I pulled one out of the archives. I've had the luxury of having this case before an infection blow up on it, because I've had the arch scan because I was treating the other side. Did you see the lateral canal? And she comes with an infection coming from the lateral canal. The same scenario, and I've seen this before. This was before I did the previous case. So it was not a surprise. And, you treat it, you do what we do, and things heal. This is It's one of Dr. Costella's patient, your office. Yeah. Any questions, comments, or concerns?
So I know when you graduated, so it's a
Uh-oh.
long time ago. And you're doing it, what, you're following 980 cases?
No. I started a protocol in January of 2013, and I dedicated a certain type of cases to it with that protocol. And now I have close to 1,000 cases since January of 2013.
Very cool.
Yeah. We have like a follow-up department, the third column, right? Oh, that's what excites us during the day. It really does. And I go, Isabel, did the post-op come? No, they didn't come. I said, call them, make sure they come, please. And I left a message. I said, that's not good enough, Isabel. Your life depends on it. I've known Isabel for 30 years, so it's okay. So she goes, I did my best. I said, that's not good enough. I need to see it. So she gets it in the next week. Okay, things feel good. Why do you want to really take a trip and go to the endodontist? But, it's all about education. You educate the patient and you show them the existing condition and you show them this is what we want, so they have a vested interest in their own case. And when they come, I go over everything with them as well. So somebody had a question back there? Yes, sir. It doesn't matter. It really doesn't matter. Okay, but you're asking a very good question. You're asking the filling. I'm enforcing what you take out, not what you put in. I use two kinds of sealer: Kerr extended working time and bioceramic sealer by Bressler. Okay? The case with the huge lateral canal, I use the BC sealer for it. Yeah. But it doesn't matter. It doesn't matter. It really doesn't matter. It's not how you fill the canal. What you do is you clean the canal and you fill it to keep the condition of the cleaning. That's what that is. So going back to the 1999 paper, this is Bill Costerton. This video was made 3 months before he passed away, and he said something that changed my life. Listen.
I'm looking to dentistry for some of the earlier ones because a single tooth that doesn't contain a whole bunch of bacteria, it's not like a cystic fibrosis lung, and perhaps we could disperse the bacteria in a root canal problem and cause them to be cleaned up with antibiotics and go at it slowly.
So I did, and I said 10 years, I'm going to follow my cases and see if it works. Then it works, so I applied for a patent, and this is the diagram. Those are the ingredients. I cannot share it with you yet, but this is the flow chart to what we do. It has 7 elements, 6. One of them is interchangeable, so there is 6. And this is the filing date, 23. I started in 23. I said 10 years, and it was published earlier this year. And I'm still waiting they're going back and forth. It's not easy to get a patent here. I'm not getting patents for money, believe me. I'm doing it for making it work. So, any questions or concerns? Yes, ma'am.
So it's so hard to get bone back with perio issues. Is that because there's so much bacteria around in the mouth in the endodontist world?
Oh, I feel sorry for periodontists.
Well, no,
I really do.
I want to know your theory on it. Why can you gain bone?
Because we can disinfect. We can get rid of the biofilm. They can't. They cannot. No, it's despite best efforts. They cannot. It's not that they don't want to do it. Because it's open to the oral environment. We can eliminate the bacteria. Because remember when I showed you the plaque? You remove it, it comes back in 10 hours. That's going to happen. You cannot stop it, right, Mike? So Schilder used to say, we can heal the disease, but the poor periodontists, they just manage it. I'm sorry. Hats off to you guys. I don't know how you do it, but the good ones, the good teeth, they survive. They survive, and you maintain them. You educate the patient, and you go through all of that.
Thank God.
But
Thank God most of the teeth survive.
Survive.
Regardless of what we do.
It's in spite of us. Yeah. It's true. The human body is so resilient. The oral cavity is incredible. is incredible. Half of the population is halfway edentulous, and they chew meat and they do well, if they can afford meat, you know. So I'm going to go over one more case with you, and it's going to show you what I tried to do. This is the second case that I've ever done under that protocol in January of 2013. So a patient comes in for tooth number 18, and he goes, Dr. Ebate, can you look at this tooth? It has double sinus tracts. I'm ready to go. I'm scheduled to go for a biopsy with the oral surgeon. Then I took a scan, and back then I had a different scan. And I said, what the hell is this? This is a big lesion, asymptomatic. And you don't expect it to be symptomatic because, first of all, this is chronic. Second, there is a sinus tract. When you have a sinus tract, the patient is going to be asymptomatic. Do not give antibiotics. Okay? No reason. Hot salt water rinses, if that. So this is the lesion. Look at it. This is not the sinus. This is the lesion. Okay, so this is the coronal view. This is the sagittal view. The whole arch is gone. So I did like a good endodontist. I put calcium hydroxide in there, and we were taught to close the case when the sinus tract heals, right? It didn't heal. I said, you're stubborn, but I'm more stubborn. I'm going to do it again. So I did another 4 weeks of calcium hydroxide. Well, I was defeated. So I told the patient, I'm working on something here, but it's not proved, it's this. He goes, I don't care. I'm going to lose this tooth anyway, right? Which is what the first patient said. She was an infectious disease professor at UCSF. Anyway, so I said, okay, let's do it. So I did it, and it was successful. The sinus tract closed. So I said, okay, I have an option to do it. Look at this lesion. Huge. And this is the sagittal view. Look at here. This is by the way, the tooth was 28 or 29 millimeters long. It perforated the floor of the nose. It's not like perforating the sinus. You perforate the nose, it's a trip to the ENT. Surgery, big surgery. It's not like perforating the sinus, okay? So you have to watch this. And also, this is we live and die by the axial view. This is the most important view. And it was big. Again, this is an old CBCT machine. It was older. But it's big. Buccal and palatal through and through lesions. Okay, so I put my medicine in there, and notice, I want you to notice this. Lateral canals. Do you see that? So if you're going to do surgery, and you're going to seal the apex, and you ignore this, it's not going anywhere. Okay? So lateral canals, and 4 weeks later, and I seal it. But if you notice, I was able to seal the apex with MTA. I wanted to maximize the outcome. And I was like, I can't wait to see this thing. I didn't think it was going to heal. I didn't have the track record. I did not have the quantification behind me. I didn't have the numbers, the statistics. I didn't think it was going to heal. And I told the patient, if it's not going to heal, I'm not going to charge you. Because I was not doing anything predictable. So this is 6 months. This is 6 months. This is the lesion. 6 months. 18 months. And I said, oh my God, it's healing. And I took a scan at that point, and it was healing. So this is what we start with. Once it heals, it tends to continue. Unless you're quieting down the biofilm, then the biofilm gets angry again and gets strong again, then things relapse. But I didn't think that was the case. So this was 18 months, and this is 6 years. Is it? Yeah, 6 years. Looks nice.
At what point did you bill him?
I was not interested in that, to be honest with you. I don't remember. This was a long time ago. I don't remember. I really don't. She probably won't remember. Honestly, I didn't care because I wanted to know. because this is how you find out what works. So this is the before, this is 6 years later, and this is 10 years later. Now notice, the bone is exactly the way God intended it. And you cannot fake this. This is not a bone graft. It just happens. The bone knows what it needs to do. So this is what? This is 6 months. This is the pre-op. And this is 10 years. Okay, now, take a look at this. I want you to appreciate the fact that I'm intentionally recalling him back after 10 years because I can't see from here, we did it in January 15th, and the 10-year recall was January 6th. It was intentional 10-year follow-up, not by chance. So I really wanted to see that case in 10 years. Any questions or comments? Okay, again, I made reference to my staff, and I was begging them for a picture, but they said they're too shy. So here they are. They're all sitting over there. So they didn't take a picture, but I said, in last time I was here, in 2018, I said, I owe 51% of my success to my staff. Then you have to revise things. I owe 51.43162% to my staff. That is the power of quantification, ladies and gentlemen. Of course I'm faking this, but what I'm trying to say is I appreciate them more. My poor assistants, I make them have lunch with me every single day. I feel bad. But we get along. So my home away from home, these beautiful people, and I gave them a part of the diagnosis lecture last year. Notice the time, 9:35. That is not AM, that is PM. Remember? And we are good friends, and we like each other in school and outside of school. And you guys give me a lot of joy, and I wish every single one of you be the best endodontist you can be. And of course, good friends like Dr. Rich Wayne, amazing man, amazing family. This is Antonio and Gavin, my son. They're best friends. They go to school together, and they always hang out, same grade. Of course, I have to give the utmost thanks for my family. My wife, she's a trooper. And my 3 kids. I love this picture because we were in Greece, and the kids were young, and they enjoy family vacations. Now they don't want to come with us. As a matter of fact, my older son is in Greece by himself studying. And I hear he's doing cliff diving and stuff like that. So I said, my wife told me that this morning. I said, please don't. I don't want to hear this right now. But appreciate them when they're young. So that's why we're not sending this guy to school. We're holding on to him. And I want to thank every single one of you for spending this time with me. I really enjoyed being here. Thank you. Any questions or comments?
Thank you.
Thank you, Ira. Thank you for coming.
Well done.
Yeah, thank you.
So, since Dr. Babe
Yes, sir.
is going to challenge the French Laundry, I have a 2017 Merlot, a nicely crafted version with berries, plums, and hints of dark chocolate on the nose and palate. Emphasize the palate. There you are, sir.
Thank you, sir. Thank you, sir. Any bottle openers? Does anybody have a bottle opener? No? And any questions or comments? Or I can always be asked in private, and you all have my cell phones. You can always call me in the office. And as you have predicted, I'm an endo nerd. I love talking about this stuff. So any questions? Yeah. I hope this was good for you guys. I can't believe